Good afternoon, everyone. It's 12 o'clock, so we're going to get started. Welcome to our cardio webinar, Primary and Secondary Prevention of Cardiovascular Disease in Women. I'm Dr. Michael Constant, the Principal Investigator of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio, and I'm joined by Dr. Sherry Boland, Co-Principal Investigator of Cardio. Founded in 2017, Cardio's mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population. Cardio brings together Ohio's 7 medical schools to identify, produce, and disseminate evidence-based cardiovascular and diabetes best practices to primary care teams. To learn more about the collaborative and to access our online repository of best practices, please visit our website, cardio.org, and download our web app. Next slide. I would like to acknowledge and thank our sponsor, the Ohio Department of Medicaid, and our administrative partner, the Ohio Colleges of Medicine Government Resource Center. I would also like to recognize the partnership of Ohio's 7 medical schools who contribute to make the Cardio Collaborative a success. Dr. Boland will now provide some logistics regarding today's webinar.
Thanks, Mike. Good afternoon, everyone. Just some brief logistics. If you are on Zoom, if you could put your name as your first and last name so we can see who you are. If you're joining as a group, please use the chat feature to record the names and emails of everyone that is with you at the group. We want you to ask questions, so please use the Q&A feature to submit questions at any point, and we'll answer those during the Q&A portion at the end of the webinar. And we do want to hear how we can make improvements in the future, so there will be a survey afterward that we hope to have you fill out and share with us your thoughts on this webinar today. These are our disclosures. Really no disclosures that affect this presentation. If you are interested in CME, when you registered, you clicked a button so that we would send you an email from Cloud CME afterward within the next week. If you didn't register, just make sure you use this QR code here to register and click that you want CME if you do want that. And with that, I will introduce Dr. Amy Zack, who will be moderating today, and we'll introduce our speaker. But Dr. Zack is a family medicine physician, vice chair of education at Cleveland Clinic, and faculty at the Case Western Reserve University School of Medicine. She serves as the head of education and dissemination for Cardio. So thank you, Dr. Zack, for moderating.
Thanks very much, Sherry. It's my pleasure today to introduce our speaker for our statewide webinar. Dr. Leslie Cho is the director of the Cleveland Clinic Women's Cardiovascular Center. She is also section head of preventive cardiology and rehabilitation and the chief quality officer in the Department of Cardiovascular Medicine at the Cleveland Clinic. She's a professor of medicine at Cleveland Clinic Lerner School of Medicine with Case Western Reserve University Medical School. Dr. Cho is board certified in interventional cardiology, cardiovascular medicine, and internal medicine. She earned her medical degree at the University of Chicago, completing residency at Johns Hopkins and fellowships in cardiology and interventional cardiology at the Cleveland Clinic. Dr. Cho's specialty interests include heart disease in women, cardiovascular prevention, microvascular disease, and hyperlipidemia. She has both been a researcher and a shaper of our national landscape in cardiovascular prevention, and particularly in women, through committee participation, publications, presentations, and talks like we have today. So it's our pleasure to introduce today Dr. Leslie Cho.
Well, thank you so much for having me. And it's really my pleasure to be with all of you today to talk about something that's very near and dear to my heart, which is primary and secondary prevention of cardiovascular disease in women. And I'm so glad you think this is an important topic because we think it's a crucial topic. And so these are our objectives: identify cardiovascular risk consideration unique to women, talk about evidence-based patient education on prevention and risk management, and screen and treat cardiovascular disease risk factor in women. So let's get started. So I don't have to tell you that the leading cause of death for both men and women is cardiovascular disease. And so let's just dive right into it and talk about, are there gender differences in risk factor, clinical manifestation, cardiac testing, and treatment and outcomes? So let's talk about risk factors. Obviously, we know these risk factors. These are drilled into our head, even from medical school: hypertension, hyperlipidemia, diabetes, smoking, and family history. But these risk factors, while we know them, they affect women and men very differently. And so I'll show you some of the data about hypertension. So for example, we know that women have hypertension. Women get hypertension later than men. But when you look at the trajectory of blood pressure increase throughout their life, that delta change is much faster for women. The risk factor for women, this is based on the Nurses' Health Study, around 89,000 healthy women. The number one risk factor is BMI greater than 30. And of course, not following the DASH diet, physical inactivity, and excessive alcohol. For women, that SALT is really a four-letter word. It's really important to maintain good body weight, but also women are exquisitely salt sensitive. It's also important to understand hypertension and how the circadian rhythm. So for women, especially postmenopausal women, they're less likely to have nighttime dipping of blood pressure. We know that dipping actually is very important. And because women are less likely to have the lowering of blood pressure in their sleep, they're more likely to experience cardiovascular events at nighttime. The other unique thing about hypertension is, of course, fibromuscular dysplasia. 90% of women, 90% of patients with fibromuscular dysplasia are women. And if you look at fibromuscular dysplasia patients, 75 to 80% of them have renal artery involvement. It's really important to think about this diagnosis when you see young women with hypertension. First line of treatment is medical therapy. If resistant, then we talk about intervention, but really most patients are quite responsive to medical therapy. And the time for diagnosis is in their 40s. As I get older, the young age changes, but 40 is the time for diagnosis. Now, we've seen as young as 30s with fibromuscular dysplasia having hypertension. So it's important to think about it and keep it in your background. So we talked about hypertension, how women are non-dippers. They have an increase in hypertension later on in their life, especially after menopause. Let's talk about diabetes. 26 million people in the US with diabetes. Half of them are women. Women have higher rates of type 2 diabetes in their youth. Women with type 2 diabetes, they don't have the protection of estrogen. So they are actually having heart disease at the same age as men, in their 40s and then 50s. And having diabetes for women is a particularly potent risk factor. And I'll show you the risk factor for heart failure, but it really is a potent risk factor for women. So when you look at the meta-analysis of 49 studies, these are 5 million patients with diabetes, it increases mortality, CVD mortality, heart disease mortality. This is a really potent risk factor. This is women compared to men. So much higher risk. If you are a woman with diabetes, you're much more likely to have cardiovascular event. This is from the Stockholm Heart Epidemiological Study. And when you are diabetic and you're a woman, you're more likely to have non-fatal myocardial infarction. It's pretty sobering to look at these data. If you're, as you know, and many of you in this audience are family medicine doctors, you know that if you're a Hispanic or Black baby girl born in America in 2020, your risk of having diabetes is 50%. That means 50% of those kids are at increased risk for having heart disease. for having non-fatal MI, and then, of course, having heart failure as well. This is the UK Biobank study looking at how diabetes increases the risk for heart failure in women. It's around 500,000 patients, follow up for 9 years. Look at this hazard ratio, 1.73. Higher rates of heart failure mortality is also increased in women. Smoking in women is associated with half of all cardiovascular events. It's actually a much more potent risk factor for heart attack in women than it is in men. And it shows a strong causal relationship with stroke as well in women. But are there unique risk factors? And of course, we wouldn't be having this talk if there weren't. So the answer is yes, and there are. And this is a paper that we published in the American College of Cardiology, looking at unique cardiovascular risk factor in women. And those have to do with adverse pregnancy outcomes. And I'll go through that with you, autoimmune disorders. And so let's dive into sort of the unique risk factors. They are preeclampsia or hypertension during pregnancy, gestational diabetes, polycystic ovarian syndrome, and early menopause. And whether that early menopause is natural, surgical, or chemically induced, as in the case of breast cancer, early menopause, there's a lot of controversy about 45, 40, but, I think 45 is a reasonable number. That increases your risk for having having heart disease. So let's look at the hypertensive disorders of pregnancy. If you have hypertension, forget preeclampsia. If you have hypertension during pregnancy, I'm even talking about the 4th trimester, especially postpartum hypertension, which we're learning a lot about. If you have hypertension during pregnancy or postpartum, you're at 2.3-fold increased risk for developing hypertension in your life. This is like a risk factor, like a stress test. So you've flunked the stress test. So you are at an increased risk for hypertension. You're at 1.6-fold increased risk for having coronary artery disease. And you're at 1.8-fold risk increase for having stroke. It is an incredibly potent risk factor for developing cardiovascular disease later on in your life. Heart failure, aortic stenosis, risk for arrhythmia, and of course, this incredibly potent risk factor for developing chronic kidney disease. Gestational diabetes, again, another potent risk factor. If you have gestational diabetes, you go on to develop diabetes, but also hypertension, ischemic heart disease as well. And that is the reason why the American College of Obstetrics and Gynecology, along with the American Heart Association and the American College of Cardiology, considers these adverse pregnancy outcomes a potent risk factor. And if you have that, then you really should be screening these people for heart disease. And it's not to start people on medications, but it's really to get them on the right pathway, getting their medical history, doing a good physical exam, getting lab testing, and really trying to change their risk factor, change their diet and their lifestyle so that they don't develop hypertension, so that they don't develop diabetes, go on to have CKD, heart attack, or heart failure. Premature menopause, of course, as we know, estrogen is a wonderful thing to have. Unfortunately, it's hard to replicate this exogenously, but estrogen withdrawal from the body, there is an increase in blood pressure, changes in your lipids, you reduce your glucose tolerance, you gain weight, and of course, there's an endothelial dysfunction component and vascular inflammation component. As the earlier the menopause, as you know, most women in America go through menopause at age 52. So earlier the menopause, less than 40 increases your risk, more than less than between 40 to 45. But early menopause actually is a very potent risk factor for having heart disease as well. Other risk factors are PCOS. And then, of course, autoimmune disease. You know, we think of autoimmune disease as something very gender neutral, but it's actually not gender neutral. It's mostly in women. And we think that actually things like mitral stenosis is a form of autoimmune disease as well. And so autoimmune disease, 80% of people with autoimmune disease are women. Rheumatoid arthritis, a very potent risk factor for having heart disease, lupus, psoriasis. And the reason for that is that when you have autoimmune disease, the whole inflammation milieu starts the atherosclerosis cycle. So there's been a lot of talk about clinical manifestations, that men and women have different clinical manifestations of heart disease. So let's dive into the data and see. So this is the patient registry, around 500,000 patients. Women are less likely to have the typical chest pressure, chest tightness. They have it, 70% of them have it, but 30% of them actually have atypical symptoms. So they have nausea as their symptoms, just shortness of breath, extreme fatigue as a symptom. When you look at the most interesting thing, I think, is from the registry, is that younger women, and we know from the registry data, the national database now, that younger women are having heart attacks because of diabetes, because of obesity. Younger women tend to have silent MIs, the sort of unrecognized MIs, because they have atypical symptoms. So the younger you are, the more atypical symptoms you have. And the older you are, they have more typical symptoms of chest pressure, chest tightness that we associate with heart disease. There is actually a fundamental difference between men and women in terms of atherosclerosis. You know, women's heart is not just smaller men's heart. There's actually a fundamental difference. There's some difference in plaque as well. So plaque erosion, that's when the cholesterol plaque erodes back into the vessel wall, is more in women than it is in men. Now, obviously, women have plaque rupture. Majority of women have plaque rupture, but plaque erosion, where the plaque erodes back into the vessel, thus causing clot formation, that actually is much more common in women. The other thing that's very, very common in women is spontaneous coronary artery dissection. That has nothing to do with plaque. That has to do when the artery dissects. And of course, there's now an increasing awareness because now we have great modalities to diagnose it. But it's the number one cause of MI in young women, less than 60 years of age in certain registries. 30% of these occur in patients with fibromuscular dysplasia. So it's really important in young women. They come in, they have this spontaneous coronary artery dissection to check for fibromuscular dysplasia. The recurrence rate is around 30%. It's really important to control their blood pressure and heart rate because we think that's the mechanism of the dissection. You have an endothelium that's not healthy, it tears, and so controlling blood pressure and heart rate is really critical. The other important thing to remember is that peripartum or postpartum, third trimester to fourth trimester, lots of times we see spontaneous coronary artery dissection also in women on hormone replacement therapy as well. So it's important to think about these things in women presenting with heart attacks after the peripartum time. The other unique heart attack that happens in women is something called myocardial infarction without obstructive coronary artery disease. So I'm an interventional cardiologist. I spend a lot of time in the big epicardial artery putting stents in, but that actually is only one half of the issue. The microvessels, the small arteries we can't see with our eyes, we can't cath, we can't bypass, we can't stent, they can become dysfunctional. And in the past, there was really no way for us to diagnose this microvessel disease, and now there is a very a good way to diagnose microvessel disease. So we're learning a lot about MNOCA, which is this microvessel disease that causes heart attack. And this actually occurs mostly in women as well. Microvessel disease actually is not benign. So when you look at some of the microvessel studies that have been done, women with microvessel disease do come in with heart attack, similar to the rates of people with epicardial coronary artery disease to the hospital with recurrent non-STEMIs. Treatment for microvessel disease, because we think it's an endothelial dysfunction problem, we treat it with aspirin, statins, ACE inhibitors, and the most potent treatment for endothelial dysfunction, which is cardiac rehab exercise. Treating the symptoms, we treat it with either ranolazine or nitroglycerin. Beta blockers, we particularly like nebivolol because we think it has a very good endothelial effect as well. And then, of course, calcium channel blockers. As I was saying to you, there is fundamental difference between coronary structures and function between men and women. And if there is one message I want you to remember when you come out of this, that is the unique risk factors and that women's heart and men's heart are fundamentally different. When you look at women's heart, it's smaller. So women's arteries are smaller. And what's fascinating is when we take a woman's heart out of a woman's body and put it into a man's heart, like we do in cardiac transplant, the arteries actually become bigger. And the other interesting thing is women's arteries have more stiffness. They have, as I told you, more sort of erosion when they have a heart attack, but they have more fibrosis. And there is actually differences in the microvessel function between men and women. The other diagnoses that are unique to women are stress-induced cardiomyopathy. So this is broken heart syndrome that we have all heard about when they're super happy or super sad or just very surprised, they can have this incredible surge in their stress hormones, which causes a heart attack. That's 90% in women. It's very much a female phenomenon. When we talk about diastolic heart failure is you have hearts that are normal in function, but you have nevertheless heart failure, that heart failure preserved ejection fraction. That is a disease of ladies because their heart muscles become stiff with hypertension. Again, predominantly a female issue. And of course, peripartum cardiomyopathy is a uniquely female phenomenon. This is a stress-induced cardiomyopathy where the entire sort of anterior wall of the heart is not working. Majority of these patients recover. The interesting thing we're learning is that besides 90% of them being women, this is a recurrent problem in some patients. And that's sort of a fascinating new disease entity. So are there differences in how we test women with heart disease? And there are. And I will give you sort of my bias. And so my bias is, we talk a lot about cardiac testing, EKG, exercise stress testing, whether we should do stress echo, stress nuclear, and I'll give you some of my thoughts on that, cardiac CT, and then cardiac catheterization. So, the EKG stress test, obviously it's super easy to do. I like EKG stress test, just to see function. It's cheap, works well in people. It has lower sensitivity. And then for women, it's particularly lower sensitivity in women because of breast tissue and there's some ST changes that occurs during menstrual cycles. And so this has sort of fallen out of favor for most part. Now, we think lower accuracy because low prevalence, lower QRS, but mainly because this ST segment abnormalities vary by menstrual cycle. Now, for older patients, you can certainly think about doing EKG, but I actually like stress testing with imaging modality. And my preference for women is stress echocardiogram. And the main reason for that is that you get good sensitivity, good specificity, but you assess the valves. And I really like assessing the valves. And, shortness of breath is never normal. And I want to say it's, I sometimes hear women, they're like, yeah, I'm getting short of breath, but I'm getting older. Okay, that's not the reason you're short of breath. And I think, valve disease are underdiagnosed in women. Valve disease are a little different in women. So I really like stress echo to look at valves as well as pressures. And then I like the fact, most importantly, for younger women, I like the fact that it has no radiation. And, I see sometimes women from outside where they come in with yearly nuclear stress tests. Nuclear stress tests can have anywhere from 500 to 1,000 chest x-ray. I mean, that's a lot of radiation to the breast. Obviously, if you are a very large patient, the image quality for stress echo is not that great. It's very much reader and technician dependent. And then in patients who've had multiple heart attacks, it's not such a great test, the stress echo. But in a good center with good readers and good technician, I think you can do okay. Now, I think the true minus to stress echo is the multiple resting wall motion abnormality. That actually is a very difficult patient population. Nuclear study, it's a great study, safe in patients, good for people who are overweight. And I think it's also, there's a lot of nuclear test centers out there, so it's easily available. The thing I don't like is that because women have smaller hearts, sometimes it's difficult, the radiation issue. And then, of course, it's very important to correct for this breast artifact. The number of people who have quote unquote abnormal stress test when it's just a breast tissue artifact is huge. And so your nuclear study, if it's in a good center, should be correcting that breast tissue attenuation. I really like cardiac CT, and the reason I like cardiac CT, I think cardiac CT has a very good role, and the role for cardiac CT, I'm not talking about the calcium score. The role for cardiac CT that's really important is for people who come in to hospitals recurrently with stress tests that are normal, that you think their probability is low. This is a great test to sort of rule out CAD. Now, some of these people you have to think about microvessel disease, but for a lot of these sort of atypical symptoms, cardiac CT is a great test. This is not the same thing as a calcium score, which is very different. Now, obviously, cardiac cath, which is how I spend Tuesdays and Friday, is the gold standard, but it's invasive. And even though it's incredibly safe to do, it's still an invasive testing. It has its, risk. The reason I like to do cardiac cath, especially for women with recurrent chest pain who've come in multiple times, is the physiology testing that we can do now for microvessel disease. And I'll show you how we do that in a couple of slides. So when we talk about microvessel disease, for years we've said, oh, you have normal coronary arteries, you have chest pain, that's not your heart, maybe it's something else. But it actually turns out it may, in some of these patients, be the microvessel. So we're not talking about large vessels, but we're talking about tiny, tiny capillaries. And the microvessel dysfunction. So microvessels should dilate when you exercise, when you're under stress, but these microvessels constrict. There's also this thing called microvessel spasm as well that we also test for. So how do we do that? The way we do that is we put a wire down, we do adenosine, and we measure the microvessel physiology. We measure the resistance. We also give medicine, acetylcholine, to test for vasoreactivity, to look for epicardia, large vessel coronary spasm, as well as microvessel spasm as well. And it's a great test. And I think for people who've had multiple admissions for heart chest pain, been ruled out for everything, this is a sort of a great test and a last resort. Now, are there differences in treatment between men and women? Well, let's start with the good news. For secondary prevention, aspirin and statin, both men and women derive great benefit. And so let's go now talking about for primary prevention. So aspirin for primary prevention, well, it's really important to think about the risk versus the benefit. So the absolute benefit of cardiovascular reduction versus the bleeding. So how can we sort of think about that? As you know, there's been 3 sort of pivotal primary prevention aspirin trials: the ARRIVE, which is moderate risk; ASCEND, which was in diabetic primary prevention; ASPREE, greater than 70 primary prevention. And really, MACE was kind of, neutral, except for ASCEND, which they did show a decrease in MACE, but there was consistently increase in bleeding. And in the elderly population, not just bleeding, but mortality. So, for sure, if we look at all the sort of meta-analysis of aspirin use, aspirin definitely lowers adverse events. It lowers heart attack. It lowers, stroke by around 11%. But what it does consistently is it increases bleeding. So CVD prevention, the number needed to treat, 265. Number needed to harm with aspirin, 210. So that's a fairly, that sort of gives us pause. But there are patient population in whom aspirin for sure works. And so let's talk about who that is. And I think this is where calcium score becomes very important. And so calcium score can be used to guide who should get aspirin. So let's just look at this, which is very interesting. So calcium score of 0, you should not be doing aspirin. Calcium score of greater than 100, look at this. Incredible in terms of number needed to harm and number needed to treat. You actually have a benefit. So the bleeding risk compared to the benefit is low. So you should be treating these people with aspirin therapy. The other group that actually would benefit from aspirin therapy is women with elevated lipoprotein A. So as you recall, the Women's Health Initiative looking at hormone replacement therapy as well as aspirin. There was a sub-study of women with elevated lipoprotein A. Women with elevated lipoprotein A had 200% increased risk for having heart attacks. And they're the ones who derived benefit from being on low-dose aspirin therapy. The other thing is that in people who are not well controlled, so you have primary prevention population, but their blood pressure is not well controlled. Their diabetes is not well controlled. Their cholesterol level is not well controlled, or they're smoking. Aspirin actually makes a lot of sense. But for most patients, you have to really sort of grapple with the number needed to harm and the number needed to treat. And I think that this sort of, for sure, aspirin in secondary prevention, but I think it's really important. If you have ASCVD risk greater than 10%, you're not well controlled with your risk factor, and your bleeding risk is low, that we still use aspirin therapy. So yes, for secondary prevention, no if you're healthy and no risk factors or greater than 70 or have bleeding risk, but really consider in people who are smokers, elevated CAC score, strong family, high lipids, uncontrolled risk factors, and Lp(a) with low bleeding risk. Now, what about cholesterol? Obviously, it's important to treat secondary prevention patients, and there is no difference between men and women for secondary prevention and cholesterol lowering. It's a mainstay of therapy. The question is in primary prevention, what about women? And there's been lots of controversy. And this is, I think, where using risk enhancers, reproductive history, autoimmune disease, Lp(a). Lp(a) is a genetic determinant risk factor. And then coronary calcium score really makes a lot of sense in when to start cholesterol-lowering medication. So the way we think about it is obviously for secondary prevention, for primary with their LDL is super high, for diabetes, because as you know, the American Diabetic Association says that if you're diabetic, even if you don't have CAD, your LDL should be less than 70. If you're high risk, obviously, and then within risk enhancers with intermediate risk. No for primary prevention if you're low risk, but maybe for people who are on borderline with risk enhancement. Now, the sad thing is that women still don't get statins, and when they do get statins, they're less likely to take it. You know, I think this is where shared decision-making is important. This is, I think, where risk-enhancing factors become really crucial. I think this is where CAC scores are really important because patients like to see their own bodies, and it's a really good sort of conversation starter to talk about how to treat aggressively and when to treat. You know, the good news is that women derive similar benefit as men in terms of hypertension. You know, this notion that we don't treat older women with blood pressure. And so, you know, we're less aggressive on that. This is how they go to have diastolic heart failure. We should aggressively be treating to target. Women derive just as similar benefit with SGLT2 inhibitors, GLP-1 receptor agonist, but they still get less aggressive care. The under treatment, I could have 10, 20 slides just talking about under treatment. You know, this is from United Kingdom, but I can show you our NHANES data too. Women are less likely to be on guideline-directed therapy. And, you know, it's critical that we keep on talking to them about it. It's critical that we drive home that women don't die of, you know, most women die of heart disease. And it's important to also emphasize that vascular dementia is a leading cause of dementia. And it's as women get older, because they live to late age, you know, that's one of the potent risk factor. Treating risk factor, vascular risk factor is good for your brain too. The good news is that women and men derive similar benefit with bypass, but they have more complications because of smaller size. And it's important to, when we talk about revascularization therapies, to sort of think about, you know, some of the medications we give. As an interventional cardiologist, it's crucial that women have radial access instead of femoral access to prevent that bleeding complication. Women are older when they have heart disease, they have more comorbidities, and it's still very sad, even in 2024, that they come to the hospital later with heart attack. Even now, even after all the American Heart Association, the ACC, all are campaigning, they still come to the ER later with STEMI. And of course, myocardium dies, and once it dies, it doesn't recover, and minutes and seconds are crucial. And so it's really important that we continue to educate our patients on symptoms. So in one of my final slides here, do women have more side effects? Is that like a thing or is that not a thing? Women absolutely have more side effects. You know, sometimes people say to me, oh, women have more side effects, they just complain more. You know what? That's not the thing, because women have, you know, babies. And it's very painful to have babies. So that's not a thing like women just complain more. Women definitely have more side effects. And that's because the pharmacokinetics are very different between men and women because of water distribution and fat. And the other important thing for us to remember as physicians and as scientists is that most clinical trials are done in men. If you look at the basic rat studies that initially start these drug trials, they're all done in male rats because they don't want to, you know, they don't want to deal with the menstrual variation. And so most of all animal studies are even done with male animals. And so if when you look at 86 drugs, most common drugs that we use, higher blood concentration and longer elimination time is seen in women. So that's why it's crucial, absolutely crucial, because of smaller body size, higher body fat content, all this stuff, that we enroll women in clinical trials. It's really important that we, make sure women have participation in clinical trials. So in conclusion, risk factors, yes, they're similar between men and women, but women have unique risk factors. And even traditional risk factors, it's really important to aggressively treat them because the adverse events that happen are different between men and women. We need more awareness. And of course, once you get diagnosed, it's really important to aggressively treat women so that they don't get heart disease. Thank you for your attention.
Thank you very much, Dr. Cho, for addressing this really important topic. I invite anybody who has questions to ask them in our Q&A, as opposed to the chat function, if you are able. And we have a few minutes to answer some questions. The first one is, would folks that have chest pain related to microvessel disease present with elevated troponins and or more typical EKG findings like we might expect in perhaps a male MI patient?
So most people with microvessel, so they definitely present with MNOCA, which is myocardial infarction of non-obstructive coronary artery disease. They have non-specific ST changes on their EKG, so not the traditional ST elevation. They have troponin elevation, and then they all get sent to the cath lab, and then they're like, oh no, arteries are blocked, so who knows what this is, and maybe it's a demand ischemia or something, and they go home and they continue to have chest pain. The troponin elevation, troponin is a marker. And so, it's really important if they have non-obstructive coronary artery disease that we look for the cause, whether it's myocarditis, whether it's, microvessel disease. It's really important to look for a cause. Majority of people with microvessel disease come in with recurrent chest pain. They don't leak enzyme. They come in with recurrent chest pain. They get stress tests, negative, or they even get a stress test that's positive. They go to the cath lab, everything's fine, so then they get sent home, but they keep on having chest pain. The interesting thing after having treated these people for 20 years is either they have chest pain with exertion or with psychological stress, or some of these people, after they exercise, they have tremendous amount of chest pain. And it hangs on for a while, but it is sort of that, related to that. And they have tremendous benefit on Nebivolol. I really like Nebivolol. But the most important thing is to treat the underlying endothelial dysfunction, which is aspirin, statins, ACE inhibitors, and of course, exercise, because exercise releases nitric oxide, which then vasodilates and helps train the endothelium.
And for those patients that you would recommend exercise for, especially if they have chest pain related with exercise, do you recommend starting with a cardiac rehab, or it's okay just to send them to walk? What would you recommend?
Well, I think it's really important if they get diagnosed with microvessel disease, angina is actually paid for, is one of the diagnoses that can pay for cardiac rehab. Patients are frequently scared to exercise, because they're having chest pain. So they're like, oh, I don't want to exercise. But, if you have the firm diagnosis of microvessel disease, what we do in cardiac rehab at the clinic is we put them on the treadmill, they exercise, they get chest pain, they stop, and they exercise once the chest pain goes away, sort of to build that tolerance. But it's nice to do it in a controlled setting. So, it's reassuring for the patients, it's reassuring for the family,
Absolutely. I guess the next question is on ARB versus ACE. And do you have thoughts about the effectiveness, or what would be your go-to?
So I mean, I think ACE and ARBs are pretty much the same. ACE inhibitors because of I like ramipril because of the endothelial function dysfunction. I think it helps with endothelial dysfunction. I like ramipril. If they can't tolerate ACE inhibitors because they have a cough, I like any ARB. As you know, losartan is the weaker of the blood pressure ARBs medicine. So a lot of these microvessel disease ladies, they don't need a big time lowering of their blood pressure. So sometimes I will choose losartan. But if they do need lowering of their blood pressure, I go with valsartan.
Thank you. Next question is around the LDL goal for patients with autoimmune disease. And I would even expand that to say, we know these patients have a higher risk. What is the LDL goal? But are there any other preventive measures or actions that should be taken in folks who fit that profile?
That's a great question. So I think autoimmune disease, especially rheumatoid arthritis, lupus, is an incredible risk enhancer. So if you look at some of the different guidelines, the ESC guidelines, it actually is almost like a CAD equivalent. That's how much of a risk enhancer it becomes. And so we at Preventive Cardiology at Cleveland Clinic, we treat them to an LDL goal of less than 70. We're very aggressive about rheumatoid arthritis or lupus. Now, the problem here is that many of these patients, there are three problems. Many of these patients are on a ton of medicines. They don't want to take it. They don't want to take another medicine. Like that's not, they don't want to take it. And that's where I think it's really important to sort of discuss the benefits of being on lower cholesterol medicine. People that worried me the most with autoimmune disease are people with frequent flares. And there's actually great data that if you have frequent flares, you have an increased risk for cardiovascular disease. And so people with frequent flares, we actually are more aggressive about getting their cholesterol down. I like getting apolipoprotein B for some of these patients. I think because it's such a potent risk factor, I think having that discussion, really showing them the data, is really critically important.
And in terms of recommendations for screening, if you are using lipoprotein A or apolipoprotein B, what would you recommend for treatment for patients who have elevations in these markers?
So lipoprotein A is a risk determinant, like a genetic risk determinant. And currently there's no medicine that lowers lipoprotein A level. There's 3 phase studies that are ongoing. If you look at the European Atherosclerotic Society consensus paper, the National Lipid Guideline consensus paper, everyone sort of recommends treating their LDL down to less than 70. There is no consensus on ApoB level, which I'll talk about in a second. But everybody sort of says you should aggressively risk modify them. So aggressively get their cholesterol down, aggressively, make sure their blood pressure and everything else is controlled. Apolipoprotein B is better as a determinant of all the atherosclerotic particles. So apolipoprotein B measures sort of all the atherosclerotic particles. For diabetic patients and for people with metabolic syndromes, apolipoprotein B actually is a better measure, I think, than just LDL alone. If there was like peace in the Middle East and there was, if I could have anything I want and order anything I want, I would get ApoB on everyone if I could get it. And if it was no cost issue, I would get it because I think it's actually, a better testing. Like, for example, people with Lp(a) that's very high, their LDL is always going to be high because LDL measurement, the way we measure LDL currently it also counts Lp(a). And so because of that, if I could do it on everybody, I would do it ApoB. But since we can't and we're cost contained, I do ApoB on people who are diabetic, metabolic syndrome, and people with elevated Lp(a).
Thank you. The next question is around your thoughts on hormone therapy and cardiac risk. And I think that this would be, hormone therapy for symptoms of menopause.
Yeah, so there are 5 societies that have come up with guidance on hormone replacement therapy: the Menopause Society, the Endocrine Society, the American Association of Clinical Endocrinologists, ACOG, and AHA and ACC. And we recently published a paper that basically states that you can take hormones for postmenopausal symptoms for the shortest amount of time. No society, 0 society, recommend you take it for prevention of cardiovascular disease. There are people in whom, now we have all these celebrities sort of pushing hormone replacement therapy, and it's become sort of like call to action. There are people who are genuinely at an increased risk. And those are people who with secondary prevention should not. So people who've had stent, people who had a heart attack, stroke, none of these people should be on hormone replacement therapy. None of them. People with spontaneous coronary artery dissection should not be on hormone replacement therapy. But for primary prevention, if you're low risk, you just started menopause, you can be on hormone replacement therapy. The people that are at risk, the intermediate risk, are people who have uncontrolled hypertension, uncontrolled diabetes, uncontrolled cholesterol. I think those people are kind of, you have to talk to people like this. But the most potent risk is people who are overweight. They have an incredible risk of developing DVT and PE. And regardless of whether you start hormone therapy at the time of menopause or not, the risk of DVT and PE is greatly increased. You can look at every study. There was recently a study that was just published in BMJ looking at the Swedish registry, and I think it was just published in BMJ this week, and looking at different compound of hormone replacement therapy. And the increase in DVT is undeniable, really undeniable. So it's really important to assess your risk.
Thank you. We have a couple follow-up questions on the autoimmune disease topic, and that is, do you use high sensitivity CRP, and at what age would you start to look at coronary risk factors in women with autoimmune disease?
So at the Cleveland Clinic, everybody with autoimmune disease, rheumatoid arthritis, lupus, etc., they get a preventative cardiology consult. And, the CRP, we love getting HSCRP. And there's a great study that came out by Paul Ritker's group out in Boston, where measuring HSCRP, Lp(a), and LDL at one time predicted your 30-year risk for having heart disease. Isn't that amazing? 30-year risk for having heart disease. So we like to measure HSCRP. Now, in patients with autoimmune disease, that's kind of tricky, right? So because, CRP is going to be elevated in that patient population, but we do like measuring HSCRP in general in women. Now, HSCRP, as you know, is kind of a tricky thing. If you're obese, your HSCRP is going to be elevated. If you have chronic gingivitis, your HSCRP is going to be elevated. HSCRP is kind of a marker that you have to sort of understand when you order, because sometimes it can go up with just a viral infection. The other thing about HSCRP is that it always increases in hormone replacement therapy, and it has to do with sort of this one pass phenomenon. But nevertheless, I like getting HSCRP. I'm not sure what to make of it with autoimmune disease patients because we treat them so aggressively.
Wonderful, thank you. Well, we have lots of other questions, and I apologize to everybody. We won't get to all of them, but I have one more minute and time for one final question, and that is, what is your viewpoint on COVID and the increased cardiovascular risk, especially in women?
That's such an interesting question, and I don't know. You're right. I mean, there is this increased risk, and I'm not sure what to make of that, and I don't know. There is a hypercoagulable aspect to it too, which I'm not sure if that, and I don't. There's a hypercoagulable aspect. There's a sort of almost an autoimmune aspect to it. And as we said, autoimmune disease is particularly prevalent in women, but it is an interesting question. And I also am kind of, there's also this huge thing about long COVID and whether that long COVID is chronic fatigue syndrome and why it affects more women. I don't know. There's so much to be done. And, one of the things that I think is really important for our audience is we have to, men and women are fundamentally different. And it's really important to continue to study the sex differences.
Thank you very much. We really appreciate you being here today and for this fantastic talk. So thank you very much, Dr. Cho. And I think Dr. Bolin.
Yeah. Thank you. Thank you, Dr. Zack, for moderating, and Dr. Cho, what a wonderful talk. So thank you so much. We will just wrap up with a few announcements, if we can. Thanks. Just a reminder, if you want CME, you need to have registered and actually clicked that you're interested in CME, so you can use this QR code or the URL in the chat if you have not done that yet. Next slide. Just a reminder that we do want to hear from you and find out what things you liked or what things we could change for future webinars that we do, and that link will come to you very soon to complete your evaluation. Next slide. And then just thank you to everybody today for attending, and we look forward to many wonderful, great events in the future. If you want to learn more about cardio.org, you can go to our website, and if you're interested in getting our monthly newsletter, you can subscribe to that there or follow us on social media. So thank you, everyone, and have a wonderful afternoon.